This video will review the assessment and fitting of the SaeboFlex for an individual who suffered a stroke resulting in moderate to severe hemiparesis. With this brief video, we will discuss what the SaeboFlex is, the criteria, we will review the fitting, as well as go over some basic troubleshooting techniques. The SaeboFlex is a wrist-hand finger orthosis that includes a finger and thumb extension system. It is specifically used to assist patients who lack the ability to extend their wrist and fingers following grasping. Ideal candidates for the SaeboFlex should have at least 15 degrees of active shoulder elevation. That could be in flexion, scaption, or abduction. 15 degrees of active elbow flexion. At least a quarter range of active finger flexion. That's going to be composite finger flexion mostly. And a minimum of 15 degrees of passive wrist extension while the fingers are in a straight position. Although you can treat patients with the Saebo orthoses that have very limited movement, ideally you would like to have a minimum of 15 degrees of active shoulder flexion and 15 degrees of active elbow flexion. As you can see here, this client does have extreme limited movement. This may lead to a more difficult recovery process. Now we're going to assess soft tissue length of the long finger flexors and thumb. While slowly bringing the wrist into extension, you want to keep the fingers completely straight. The optimal wrist position is 35 degrees of extension with the fingers fully extended. If you are unable to achieve 35 degrees of wrist extension, then a minimum of 15 degrees of wrist extension with the fingers straight is needed. While keeping the client's wrist and fingers in an extended position, she must be able to actively generate a quarter range of finger flexion to qualify. Here you can see she has enough active movement to meet the criteria. Next, we're going to assess reaching and grasping. As you can see, because of the tone in the biceps, she supinates and flexes her elbow. She's unable to straighten her elbow, pronate, or extend her wrist and fingers to put her hand in position to grasp the ball. Once you assess your client's proximal and distal movement criteria and determine if he or she is appropriate, you are now ready to begin the SaeboFlex fitting. Step 1 is to apply the forearm shell onto the patient's forearm. As you can see, you want to identify the head of the ulna, and you would like to apply the forearm shell just proximal to the head of the ulna. Once the forearm shell is in the correct position, you will tighten down the forearm shell using the two straps provided. There's a proximal and a distal strap. You'll want to cinch those down so they're nice and secure. Once the forearm is in the correct position, you're going to look at the overall length of the SaeboFlex. To do this, you're going to unhook the spring, let the digicaps hang down, and we're going to adjust the overall length. To determine the proper length, you'll want to bring the hand up against the dorsal handpiece. If they have a lot of tone, you'll have to hook your fingers underneath theirs. As you bring it up, you'll want to have the distal edge of the dorsal handpiece to be as close to the PIP joints as possible without covering them. That's for moderate to severe tone. For mild tone, you can be about a ½ inch to a ¼ inch. Now, if we want to shorten the unit, we would loosen the screws on the forearm shell and bring the handpiece back. If we want to lengthen the unit, as seen here, we're going to loosen the screws on the handpiece and bring the handpiece distal or closer to the PIP joints. Once you're in the correct position, you'll tighten down and you'll apply the hand strap. Please note there are 3 holes on the hand strap, so you can adjust the hand strap on the radial side based on if they have MCP hyperextension or the hand strap is interfering with the web space. So feel free to make that adjustment. Once you're in the correct position, tighten down the hand strap. And now you'll have the forearm strap secure as well as the hand strap. Next, we're going to rehook the spring back onto the eye hook of the forearm shell and disconnect the digicaps. If this was a custom device, when you disconnect the digicaps, they would not be able to fall through the finger lead mount opening as you see here. Since this is a prefabricated device out of our kit, the holes are larger on the finger lead mounts, so it's more convenient for multiple patients to use. Once the overall length is determined, it's time to apply the digit caps to digits 2 through 5. We are going to start with the index finger first. You'll unhook the strap. If the client has moderate to severe tone, you're going to want to stretch the finger for at least 5 to 10 seconds. This will help with reducing the tone and making the donning process of the digicap much easier. Next, you will slide the digicap proximally up the finger. I like to insert my finger into the opening of the digicap and lift the finger pad and slide it up proximally, then secure it. That seems to work well. At this point, you're going to straighten the digit and determine the overall angle of pull. You determine the angle of pull by adjusting the finger lead mount. So you loosen up the screw and slide the finger lead mount proximal or distal. You'll then straighten the PIP joint, bring the digit up so the crimp is touching the finger lead mount, and you're looking for just behind 90 degrees for angle of pull. Two ways to do that is look straight down where you can see the crimp coming through the hole, or you can look from the side where you see the angles just behind 90. Once you are pleased with the angle of pull, you'll secure the screw to the finger lead mount and reconnect the bead line to the lead line. For the index finger, you're looking for the most radial bead line. That will be your index bead line. With the one hand, you're going to maintain tension to keep the digit straight. With the other hand, you're going to pull the bead line down and connect. You'll repeat the process for the other digits. So for the middle finger, we'll stretch it out again for a few seconds to try to reduce some of the tone. Keep the finger as straight as possible. Apply the digit cap by lifting up the finger pad and sliding the digit cap proximally, and then re-securing the digit cap strap. Then you'll bring the digit cap line through the finger lead mount opening while keeping the third digit as straight as possible. We're going to adjust the angle of pull. Again, you want to be just behind 90, so the crimp is touching the finger lead mount opening, and you're looking down to see if you can see part of the crimp, or you can look from the side to make sure that angle is just behind 90. Then you'll reconnect the bead line to the lead line of the third digit using the appropriate middle finger bead line. Sometimes you'll notice when adjusting the tension, the tone will kick in. The fingers will want to flex a little. It is okay to stretch the digits while their fingers are in the digit caps to reduce some of the tone. You'll also notice that the MCPs are hyperextending a little on the radial side. We'll address that later and we'll discuss some steps on how to correct that. Next, you're going to apply the ring finger digit cap. Again, slide it on proximally. Use your finger to lift the finger pad and then position appropriately. You'll then tighten the strap down, put the digit cap line through the ring finger lead mount opening, and again we'll loosen the finger lead mount to adjust the angle of pull. We'll slide the finger lead mount a little distally. It's hard for you to see the angle here, but we're going to want to follow the same steps where you want the angle of pull to be just behind 90 degrees. You can do that two ways. You can do that by looking down the finger lead mount opening where you'll see part of the digit cap crimp, or you can look from the side where the angle is just behind 90. Once you are happy with the angle, then reconnect the ring finger bead line to the lead line. Feel free to adjust any of the finger lead mounts to get that nice arc, and then finish with the fifth digit, doing the same process. After reattaching the bead lines to the lead lines for all four digits, the crimp should be touching the finger lead mounts and the PIP joints should be in as much of a neutral position as possible. Now, looking at the thumb, we want to first understand the thumb length adjustments. You can slide the thumb line guide distal or proximal. You can also slide the thumb lead mount distal or proximal, as well as into abduction or adduction by rotating the thumb lead mount superiorly or inferiorly. You can also slide the thumb mount distal or proximal as well. To determine the proper position of the thumb, you don't want to have the client's thumb in too much radial abduction or too much palmar abduction. You want to have it right in the middle with the whip space on stretch. Then you're going to slide the digicap on the thumb proximally. You can lift the thumb pad up and secure the digicap onto the thumb and tighten a strap. Then we need to determine the overall length of the thumb assembly. Again, you can loosen it and change any of the thumb components and then re-secure. So you want to have the thumb on a nice stretch with the web space on stretch and the angle of pull just behind 90 where the crimp's touching the thumb line guide. Therefore, you want to passively stretch the thumb into the correct position and then bring the thumb assembly so it's just behind 90 degrees with the web space on stretch. When you have that correct position, tighten down the different components. And again, you want to make sure the thumb line guide is making contact with the digicap crimp. So you'll have that web space on stretch. What you see here is the patient has dorsal subluxation at the MCP. We've already attached a thumb strap. This is thumb strap number 1. You'll wrap it around the dorsum of the MCP of the thumb. Then you'll go across the palm and reconnect onto the ulnar side of the dorsal handpiece between the wrist mount and the D-ring. Previously, we discussed how this client exhibits MCP hyperextension of the index finger and middle finger. When you apply pressure downward on the proximal phalanx, the PIP joint goes to a neutral position. Same with the index finger. A good solution to address the MCP hyperextension is to take some padding. We like to use blue foam tube padding. This is an easy solution. You can cut a piece of padding. It's shaped like a ring. Then you will disconnect the bead line from the lead line and take the digicap off. And then you'll slide the blue foam ring up over the PIP joint and let it sit close to the MCP joint. So it now occupies that space between the proximal phalanx and the dorsal handpiece. When you slide the digicap back onto the digit and then reapply the lead line to the bead line, you'll notice immediately that the PIP joint is now in a neutral position. It's a great solution to address the MCP hyperextension. As you can see, you'll do the same exact thing with the third digit. When I push down on the proximal phalanx, the PIP joint went to a neutral position. Therefore, cut another ring of the blue foam tube, then apply the blue foam ring onto the third digit, slide it up towards the MCP so it fills that space directly underneath the dorsal handpiece. And again, slide the digicap for the third digit all the way on. You can lift that finger pad up, slide it in, then bring the lead line through the finger lead mount opening and connect it to the bead line, and you'll notice immediately that the PIP joint is now in a neutral position. You'll want to then adjust your attention accordingly so you can find that nice neutral position. Finally, to fine-tune your angle of pulls, feel free to splay your finger lead mounts in a radial or ulnar position. Once you're happy with the fitting, we're going to have the patient attempt to grasp the ball. We're going to put the ball between the thumb, index, and middle digit. We're going to have them grasp, and then you're going to want them to stop grasping or relaxing. You don't want them to try to open up or extend their fingers because the tone will kick in more. As you can see here, the patient has a hard time letting go of the ball by relaxing. So instead of waiting a long time, just take the ball out of the patient's hand, re-stretch the fingers out. In the beginning, there's going to be a lot of tone when they go to grasp. They're not used to this concept of actively, volitionally grasping or flexing their fingers. So stretch the fingers for about 5-10 seconds. Stretch the thumb. Let the tone relax. And then repeat the process. You'll need to do this potentially 5 or 10 times before the patient really gets comfortable with the idea of grasping and then stop grasping or releasing or relaxing. If you think you need to shorten up the bead lines, feel free to do that. If the patient has a hard time relaxing or deactivating the flexors once they grasp, you may need to increase the tension. You can do that by shortening the bead lines or switching to a stronger spring. In the beginning, I like to first fine-tune by shortening the bead lines per digit. So now that the digits are stretched, I'm just reapplying the thumb strap here to make sure that is secure. And then we're going to put the ball back into the palm on the radial side. I'm asking her to just gently squeeze. Don't squeeze hard, just gently squeeze, and then try to relax or stop squeezing. As you can see there, she was able to squeeze and then stop squeezing. And again, you re-stretch the fingers out. And then you'll attempt to have the patient grasp again. Soft, gentle squeeze. The harder they squeeze, the harder it's going to be to relax. So you want a soft, gentle squeeze, thumb, index, and possibly middle finger touching in the beginning, and then say relax or stop squeezing. But try to avoid saying extend your fingers or open your hand, as that will lead to increased exertion, which will result in increased tone. Once you're successful with grasp and release in a seated position, try to do it in standing. You'll want to have the ball in front of the patient. Again, ball placement is going to be very important. You want the thumb to make contact with the ball as well as the index finger and possibly the third digit if possible in the beginning. Have the patient actively squeeze. Try to transfer the ball to a small target such as a 4-inch yellow tube to start. You'll notice sometimes when you switch from a seated position to a standing position, the tone in the hand increases. In this situation, that's what you're seeing. So she cannot relax. So I'm lifting up each digit to find the culprit, if you will. When I lifted up the index finger, the ball dropped. So you'll want to shorten the bead line on the index finger, potentially the middle finger or any other digits that are appropriate. Also, you'll notice on the 5th digit, it's radially deviating. It's flexing at the PIP joint and deviating towards the palm. To address this, you can increase the tension of the 5th digit by adjusting the bead line. You'd want to make it so it's more an extension. If it's higher than the ring finger, it can act as a block when the fingers are flexing. Also, you can rotate the D ring so the hand strap is more distal, or you could go to the distal hole. That will provide more support at the proximal phalanx of the 5th digit and block the 5th digit from deviating laterally. Finally, you can use a buddy strap where you connect the two. So when the patient goes to grasp and transfers it over to the 4-inch yellow tube, you'll notice that the 5th digit is no longer deviating. You'll also notice that there's mild radial deviation of the middle finger. If it was more significant, you would do a bipole, and you can learn that online through our website. To fix a mild deviation, just splay the finger lead mounts in an opposite direction, in this case an ulnar direction, and that will pull the 3rd digit back to a neutral position. When the client goes to grasp again, she'll take it over to the 4-inch tube, and you'll notice the 3rd digit is a better position. In addition to having the client grasp the ball from the tabletop position, you can also do side-by-side treatment where you feed the ball to the client and have them bring the arm forward. This is especially good for individuals that lack a lot of shoulder movement. You can guide them by placing the ball into the palm of their hand, having them squeeze, and then transferring the ball over, in this case to the 4-inch yellow tube. It's not as challenging as a higher level shoulder drill, but it's challenging enough for the client. While working with your client, you may notice that the ball is dropping prematurely. This is due to fatigue of the finger flexors. If this happens consistently, you're going to want to add a weaker spring to the keychain. In this situation, we're going to be adding a yellow spring, which is weaker than the red spring that she was using. This will allow the client to continue with the grasp and release exercises and maximize the repetitions. Now, conversely, if the client has a difficult time relaxing or letting go of the ball, then you would switch back to the red spring so they can continue on with the grasp and release tasks. Once you're satisfied with the finger lead mount position on the custom SaeboFlex, Be sure to lock down the finger lead mounts with the self-tapping Phillips screw that's provided. Thank you for watching. We hope you enjoyed this video of a SaeboFlex fitting for a patient suffering moderate to severe hemiparesis. For more information on troubleshooting techniques, be sure to log on to our website at saebo.com. Thank you.